Good evening. It's my pleasure representing the Dolan Annual Lecture Committee to welcome you to the 15th Annual Dolan Lecture. We're very proud of our track record, and this evening stands to be a smasher. We've all been indulged with political events on the television, and I noticed over the week that when the reporters go to the headquarters of one of the candidates, where you can tell the results are going to be good, they all have that phrase, "You can feel the electricity." Well, looking around this room this evening at all the radiologists here, I can feel the radioactivity. It would be remiss to not mention a few words about the guy who brought us to the dance, Dr. Bill Dolan. Much of his efforts resulted in this wonderful auditorium with the classrooms. And I guess his biggest accomplishment for the community and for this hospital was the early affiliation with the Georgetown Medical School, which has provided house staff, which is a great, great benefit, not only to the hospital, but to the community in general. My fellow members of the committee are here: Dr. Ryan, Dr. Correnti, John Dolan, me, Larry Gatos, Don Nolan, and who did I miss, John? And, I'm sorry, and John Long, and Maureen O'Regan. She's on her way. Anyway, thank you all for being here. And the format will be that Barry's going to give his talk, and we ask you to hold the questions until because he's run out of material, and then we will have questions. Thank you again for coming in. John Long, please.
I'm delighted to have the opportunity to introduce the speaker for the 15th Annual Dolan Lecture. The mandate of this lecture series has been to find speakers who are at the cutting edge of medicine, speakers who contribute to our medical staff's knowledge about newer procedures, innovations, and directions that medicine is taking. Speakers who will help us in the care of our patients at Virginia Hospital Center, just as William Dolan, for whom this lecture series is named, did for so many years. Life is a journey, and as a journey, we are all exposed to individuals whose input on our journey is so profound that it affects the outcome of our personal careers. Over the last 15 years, the Dolan Lecture has attempted to find these special individuals, and it has succeeded in doing so. Dr. Barry Katzen is another one of these special individuals, who not only had a vision of interventional radiology. Many have vision, but unlike the many, he had the energy and drive to create what he envisioned. Dr. Katzen brought interventional radiology to the mainstream of medicine and out of the lab to patient care. Dr. Katzen helped turn interventional radiology into a consultative field and brought science and patient care together. There are few like him with this skill. Several physicians in this room have been influenced by Dr. Katzen in their personal career decisions. They have chosen interventional radiology as their life's work as their journeys encountered this special individual. Dr. Katzen is one of the earliest true interventional radiologists. His CV speaks for itself. From radiologic training at Cornell and St. Vincent's Hospitals in New York City, he progressed to found and currently directs the Miami Cardiac and Vascular Institute. A CV does not always give a true insight to the man, however. I have personally known Dr. Katzen for over 20 years. He's never been unavailable, particularly if you needed guidance or advice in matters of patient care. With Dr. Katzen, the patient has always come first. He has not only great vision, but the energy and courage to do what is right for the patient. His is a rare and unusual combination. I'm honored to welcome Dr. Katzen to the Miami Vascular Institute as our 15th Dolan Lecturer to give you interventional radiology present and future. Thank you, Dr. Katzen, for honoring our lecture series with your talk and presence.
Thank you very much, John, and Ken as well, and the entire committee for selecting me and inviting me to be part of this incredible lecture series. Just give me 1 minute, and I think I'm going to turn this on because I tend to move around. It's a real pleasure to come back to Northern Virginia. For those of you that may not know, I lived here for 12 years, and in many ways, the most exciting years of my life professionally were here in Northern Virginia when I was at Alexandria Hospital. And during that time, I had the opportunity to meet many of the physicians at Arlington Hospital, both within radiology and within medicine and surgery as well, and I really have always treasured those relationships. Additionally, what many of you may not know was I began the spirit of collaboration and working and bringing our two hospitals and groups together. Thank you. To really bring the first MRI facility here together. It was halfway between both hospitals because the CON law wouldn't let us get individual centers, and we had a very successful collaborative venture that allowed us to compete with Fairfax Hospital and, more importantly, bring new technology to our patients in our own communities. And during that time, I had the opportunity to meet many of the folks here at Arlington Hospital, and I think we have great memories of that time. What I'm going to talk to you about now is a field that has become a field but wasn't a field when we all started our careers. And I hope during that time to give you a sense of what interventional radiology is. And it used to be you could do this in a 20-minute talk. And I know that I have time, and I'm going to try and keep you all interested and entertained tonight as I show you the diversity of interventional radiology. But most importantly, I'd like to give you an understanding for what the effect of interventional radiology has been on medicine in general, through the diversity of the procedures that it's involved, and more importantly, this entire movement towards less invasive treatment of disease, which now has worked its way through virtually every discipline in medicine, up to and including cardiac surgery, where we're doing robotics and making attempts at less invasive approaches. And it all derives from this field called interventional radiology that developed about and was pioneered about 40 years ago. So one of the questions that most of us have as interventional radiologists is explaining what we are to our parents, to our families, to everyone that we have to interact with. And internally, this is something of a joke within the radiology community, in that our lives are so complex in terms of the diversity that we have trouble explaining what we are. And in fact, this results in an image problem, because I think it's pretty clear to understand what a surgeon is, what a cardiologist is, what a urologist is. But understanding what an interventional radiologist is very difficult to capture in a single statement, in a graphic image, or in any other way. And so as a result, I'm going to take the next several minutes or 50 minutes or so of this lecture to try and give you some sense of that. In some ways, trying to put words to this image, interventional radiology is a field of image-guided, minimally invasive therapies, although it started out with diagnoses, with applications that cross virtually every organ system and impact on pretty much every disease and disease process in the body. And the fact that it's so diverse and is brought together by this concept of image guidance makes it sort of diffuse in a lot of ways and somewhat difficult to describe. But we know what interventionalists are, interventional radiologists are. We tend to be innovative, very dynamic problem solvers. Most of us are challenged by solving the unknown. And for those of you that practice clinical medicine, it may not be uncommon for you to go down to the radiology department and ask your interventionalist or present a problem that you have no idea what the solution is, but you're going to count on the interventionalist to try and think of some new jury-rigged way to try and solve that problem. And we like being in that position. We use imaging to guide what we do to avoid surgical wounds. That's a common thread pretty much in what we do. We work in multiple organ systems. We tend to work in a highly integrated, highly collaborative fashion with a variety of disciplines throughout medicine. And our primary focus, and what's really evolved in the last 20 years, is the concept of being able to bring less invasive treatment to our patients to avoid and improve upon whatever the status quo is. So whatever the status quo is, that's our target, and we're trying to improve on that in any way possible. Well, within our field, the gentleman who's given the credit to be the father of our discipline is a man named Charles Dotter, who at one time was actually nominated for a Nobel Prize and looks a little bit like the most scary man you've ever seen. And that was part of the problem, in fact. Charles was a brilliant innovator, but we've learned from Charles's experience that having the great ideas and having the inventions is not enough. You have to be able to disseminate technology, convince everybody else that it's a good thing for the technology to have impact. But when Charles wrote his first landmark paper with another famous radiologist named Melvin Judkins, who many of you may have known because he pioneered some of the early coronary catheterization catheters. But he described angioplasty in this landmark article, which was published in 1964. And during that time, which is 40 years ago, he predicted the use of balloon angioplasty, which did not exist, the ability to drill our way through occlusions, the ability to do this kind of new treatment on an outpatient basis. More importantly, the potential to apply it to the heart, to the kidneys, to the carotid circulation, and virtually all parts of the circulation. And then he also predicted endovascular splints, that, as he called them, that have subsequently become what you'll know as stents. And I'll talk to you more about that. Now, in looking at the world of interventional radiology, we're very solution-oriented. And it's not so much technique-oriented as problem-solving oriented. And the next couple of slides are intended to give you some idea of what the order of magnitude is of this. If we look at the clinical problem of acute abdomen, and I hope you can all see this. I'm getting a little bit of a glare. If not, we can bring the lights down a little bit. But you may recall that the #1 procedure done 20 years ago here in the United States was an exploratory laparotomy. That procedure now is pretty much history for a lot of different reasons. But because of the development of CT and image-guided drainage, which actually was pioneered here in Northern Virginia to a large extent, where we did many of the first body scans and liver abscess drainages and so on, we've been able to avoid more extensive surgery. So in the area of general surgery, this is one application. In the area of hydronephrosis, where the treatment had been surgical nephrostomy, the development of percutaneous nephrostomy, these are procedures where we basically use imaging and we can go in and drain an obstructed kidney, replace that. Removal of kidney stones was at one time done totally with surgery. Now it's done by lithotripsy and combinations of percutaneous techniques as well. So in the GU system, you can see the applications. In the bile ducts, patients with biliary obstruction, these can, by and large, be managed with percutaneous techniques. Again, I mentioned the issue of exploratory laparotomy. Image-guided needle biopsies now are one of the most widely used interventional procedures to be able to combine sophisticated pathologic techniques, the ability to make a diagnosis with a single cell, along with the ability to sample without having to subject our patients to more extensive procedures. In vascular disease, an area that's been a lifelong interest of mine, in symptomatic peripheral arterial disease, in the 1960s, the principal treatment was endarterectomy and bypass surgery, and to a large extent, much of this can be done now with angioplasty and stenting. Patients who are bleeding internally, have internal hemorrhage, whose surgical exploration and surgical exclusion of this bleeding was the only choice, or treatment of performance of portacable shunting, has been replaced by a procedure where we can actually create a bypass inside the liver coming from the neck. So these types of approaches and solutions interventional radiology works in. In patients who have severe hypertension due to narrowings of their renal arteries, bypass can be avoided with renal artery stenting. Patients who can't be fed and in the past have required surgical gastrostomies and that can have tubes placed percutaneously or more recently endoscopically. And the fact that something more transitions from percutaneous to another less invasive modality is not really important to us because it's making that transition from whatever the status quo is to the next less invasive approach that's really important. Here's a variety of other types of diseases. I'm just going to highlight them. Problems in the lungs, women's health care with uterine fibroids, patients who are bleeding from colonic bleeding sources, patients who have subarachnoid hemorrhage into their brains due to aneurysms, and of course the most important from a volume point of view is patients with coronary artery disease affected by angioplasty and stenting, a direct outcome of these movements that we're talking about. So the development of interventional radiology and its diversity began the movement towards less invasive therapy that's driving virtually every discipline of medicine today. Some of the areas that we work in I've highlighted already, but one of the areas is in the treatment of vascular disease, biliary, GU, neuro, and women's health. And what I'm going to try and do this evening is just highlight some of these and talk to you a little bit about some of the technology that we're interested in I'm not going to confound you with a lot of data because we have a diverse group, and I'm just going to try and give you a snapshot of the world of interventional radiology and what its impact has been. And in looking at vascular diseases, meaning non-cardiac circulatory diseases, you can see from this list that there's a whole host of areas where interventional radiology has had an impact on how we treat our patients. For us, innovation is the fuel that drives the engine of our discipline. It drives us intellectually, it drives us practically, and it drives us across every system. And we try and take the solutions of one system and apply them to another. And it's a peculiar thing if you talk to people who deal with us in industry or in healthcare management. It's a very distinct intellectual approach that differentiates us from organ system-oriented disciplines like cardiology or urology or hepatology or whatever it might be. But we're constantly striving for innovation. And as I mentioned, Dr. Dotter was not only the pioneer of angioplasty, which is one of the hallmarks of what we do, but he also pioneered many of the other procedures that I talked to you about earlier. Now, one of the problems that we have faced because we have not participated in direct patient care is what you see here, which is a requisition for a diagnostic angiogram admonishing Dr. Dotter to take a look, but don't dare fix it. And because someone else was involved with fixing it. And this has been a barrier to dissemination of technology in our country. It's why angioplasty was invented in this country, but really developed in Europe. And it's a burden we've had to live with, and I think this is an interesting historical document and why you'll hear at the end of this discussion why we feel so importantly that interventional radiology itself has to mature into a different discipline. I thought I'd share with you some of the historic, in looking back, some of the historic devices. We think about what goes on in the heart. Now, people come in and get a coronary angioplasty, go home the next morning, go back to work 48 hours later. But it's been a long road to get from what you see in front of you to that point. And these are some of the early concepts where early interventionalists tried to struggle with the idea, how do you go into an artery small, do something big, and then get out without injuring the artery? And this was an idea that was developed by an East German gentleman who was actually friends with Charles named Porstmann, and he worked at a hospital called Charité, which was in East Berlin at the time. And this was actually the first balloon catheter that was commercialized. It looks like a primitive device. It is a primitive device. It represents just essentially a Teflon sleeve with some slits cut in it, and then a balloon in the inside to constrain it. And I actually am old enough to have done angioplasty, and some of you here may have been using this device, and it was a very bloody experience where we actually quantitated blood loss as a way of pioneering less invasive approaches. Well, Charles Dotter, who was a radiologist, I think I mentioned that earlier, his ideas were taken to Europe because the United States was not a very fertile ground for idea development at the time. And a number of people were involved in the middle, but the next gentleman was a man named Andreas Grunzig, who many think was a cardiologist, but actually was not a cardiologist. He was an angiologist and worked in the interventional radiology department where he trained. And he made the transition that really revolutionized things in terms of modern day angioplasty, transitioning from those crude devices to a unique balloon catheter. And angioplasty, the story I think all of you are aware, has become one of the widest used procedures. It's kind of interesting because if you look at angioplasty in the dictionary, in the medical dictionary, it is actually called a surgical procedure, even though most of us who do it don't consider it a surgical procedure, consider it as an alternative to surgery. But as you can see from this list, the concept of balloon dilation can be applied across a diverse group of structures in the vascular tree and also outside of the vascular tree. But what we've learned is that angioplasty itself has limitations. And the original theories of why angioplasty worked that were proposed by Andreas Grunzig have turned out to be totally erroneous, of course. We understand angioplasty much better at this point. And we know that angioplasty has an Achilles heel called restenosis due to intimal hyperplasia, which limits its long-term efficacy. And so there were problems with angioplasty, and as we became more experienced and developed more knowledge about angioplasty itself, we began to identify the problems that you see here. And in terms of peripheral vascular disease, we know that patients who have a blockage in the artery in their leg, this happens to be a leg artery, we can go in now without an operation, create a new channel through this total blockage, use an angioplasty and or a stent, and get a good initial result. but that our long-term patency really won't be quite as good as surgery, and that we have an Achilles heel here that needs to be dealt with. And some of the outcomes of angioplasty in the legs particularly have been less than great, and this data here essentially is just to really indicate that we can get a good initial result, but it's still a problem with getting long-term durable results. And that's led to a whole host of technology, much of which you may be familiar with, that include everything from clot blasters, lasers, ultrasound devices, freezing plaque, heating plaque, removing plaque with different types of things, the use of gene therapy, radiation therapy. All of these things are designed collectively to improve the results of the suboptimal outcome of angioplasty. And they include, of course, stents, which I'm going to talk about in more detail. So we haven't quite gotten where we want to go, but we know that we can avoid surgery or more extensive procedures in many, many patients. Well, stents, which many of you have heard about, represent a good part of the infrastructure of what we do today as interventional radiologists. And stents were also described in the late 1960s and consisted early on of these very simple coil wires which could go in small and provide a scaffolding to the blood vessel. Other ideas were also proposed, and this relatively simple idea, the zigzag or Z-stent, has become really an important part of the infrastructure of something for aneurysm treatment that I'll talk to you about in a moment. Another interventional radiologist who was a pioneer that many of you may have heard of was Julio Palmaz, who was an interventional radiologist and was the inventor of the first balloon expandable stent. Many of you in this audience may actually have stents in your heart or kidneys or legs. And it was really due to Palmaz's initial invention and then popularization and great science that allowed us to be able to really overcome this Achilles heel of angioplasty. I thought you might be interested in some of this historic information because we don't get to see it that often. This was a relatively primitive version of the first Palmaz stent prototype, but now it's become a much more sophisticated device which gets mounted on a balloon and goes in small and can be expanded up to a large size and essentially become a brace in an artery. And the first patient ever treated with a Palmaz stent was this patient that had a long blockage of an iliac artery that would have required a major surgical procedure. And you can see Dr. Palmaz and Getz Richter, this patient was treated in Heidelberg, were able to create a new channel and reconstruct essentially the blood vessel from the inside rather than having to operate from the outside. Of course, this made big press, particularly in the National Enquirer, which was the first notice of this new tube implant. It was very hard to get press at that time as a radiologist. However, as many of you know, sometimes the impact of that type of thing can be quite good. Well, anyway, I remember we actually did the first renal angioplasty in the United States right here in Northern Virginia. And it was a very big deal at the time because that had required very major surgery. But the first news report of it was, in fact, in the National Enquirer. That's another story. I can tell you how that happened at another time. But, well, these stents have now come on to become a very important part of opening up blocked blood vessels, and the extent of which you can see here. When we look at the applications of stents to different types of circulations, it's almost impossible for us here in the United States to do angioplasty without the use of stents, although you can see there are some areas where it's had greater value than others. And we'll talk about some of those as we go along. And here's just an example of three things. One is, this is a magnetic resonance angiogram, and I'm not going to talk much about this, but MRA, or as you probably know, is non-invasive and allows us to see blood vessels pretty much as well as putting invasive catheters in. And by finding critical narrowings non-invasively, we think we're going to be able to help many more patients. And in this case, you can see a critical narrowing here, and this is what it looks like after an angioplasty and a stent. Well, now that we have balloons and we have stents, again, interventional radiologists and others start thinking about how we can use this as a platform to extend this less invasive approach to other types of therapies. One of the areas that we've been interested for many, many years are abdominal aortic and other types of aneurysms. And for those of you who don't know, aneurysms are diseases of the blood vessels, but instead of the arteries becoming blocked, they get weakening in the walls and they start to balloon out, as you see here, in different kinds of configurations. And generally, the way they manifest themselves is by sudden death. And patients will get a ruptured aneurysm, And at that point, generally, saving the patient is done with not the greatest frequency. It has very high mortality rates. So the direction of treatment is to try and treat these things before they actually rupture and threaten the patient's life. And the one thing we know about aneurysms is that the risk of rupture increases with size. And if you look at aneurysms of 5 centimeters or so, the 5-year risk of rupture is relatively low. But as the aneurysm increases to sizes, let's say, of 7 centimeters in diameter, the 5-year risk of rupture is 95%. Therefore, and the 5-year survival rate is only 5%. And so the clinical judgment comes into how and when to treat these patients. And the surgical treatment of these is to open up the aneurysm and to actually take this diseased arterial pipeline and put a new synthetic pipeline in there surgically. This has been the traditional way of doing it, so that now the patient has a new artificial pipeline inside of this diseased pipeline. And then it's all sewn up, and the patient recovers, and so on. And it's pretty extensive surgery, but it is the gold standard, and has been the gold standard, and has obviously saved many, many lives. But there are mortality rates, and there are high-risk patients for survival of this type of procedure. And one of the things interventionalists do is take this technology and try and apply it first to our high-risk patients who can benefit the most from it. And then if it works and it has high clinical value, then it will work its way into the mainstream into sort of low-risk patients. The concept of an endograft, now that we have stents and other devices, is to take this aneurysm, as you see here, and essentially reconstruct a new blood vessel inside, but instead of operating, to do it all from the inside. So the idea of constructing a device inside the body, rather than constructing it outside the body and then putting it in, is one of the concepts that's involved in endografts for abdominal aortic aneurysm. And the father of this procedure is a vascular surgeon from Argentina who worked very closely with 2 interventional radiologists in developing this. One was Julio Palmaz, another was Claudio Schoenholz. And the idea here was to take the graft and to use a stent instead of sewing the graft, to use the stent as a fixation device. And this is actually the first patient that was ever treated with an aneurysm. He was treated by Juan Perotti, Julio Palmaz, and Claudio Schoenholz in September of 1990. This patient is actually still alive. And it was a very simple tube graft that was actually put in. So the concept of one technology enabling another is a very important one in terms of how we feed off technology. And these are the 2, well, there are actually 3. A third graft was actually approved this week. But here are 2 different endografts where you can see metal, which is used as stents in different ways to attach the graft into position. The treatment of aneurysms has become a very important activity for interventionalists and vascular surgeons, and about 25% of all patients with aneurysms in the United States are treated with this new, less invasive endovascular technique. The other thing we've done is explored ways of doing this in environments that are slightly less intense, or combining imaging, I would say, with the surgical environment. And this is what you're seeing here is what looks like a very highly complex, elaborate environment, which it is. And we're working with a surgeon and interventional radiologist together here in essentially a catheterization suite environment. What we proved over the past decade is that you can actually do surgery outside the operating room in these collaborative environments to optimize the need for sophisticated imaging with sterile environments. This is something that's become very important, which is a cell saver device. We're able to give the patient back their own blood, so that blood loss and the need for blood transfusion is essentially totally eliminated with this procedure. And here's an example of what this looks like. You can see a big aneurysm here, and I think it's pretty simple to see that the aneurysm is replaced now by this new synthetic pipeline. And here's some of the different configurations of how this looks graphically, just to get a feel for it. Here's a device that's a little different than the other one. It's got multiple components, and we do literally construct it inside the patient's body. There was another device literally just approved, given final approval yesterday by the FDA, that looks a lot different than the other ones, and I'm not going to go into any of these in detail, but these, for those of us treating our patients, these delivery devices are getting smaller and smaller, so that at the size of these devices, we can almost do these, or can do these in many patients without any incision whatsoever, which is, I think, a landmark advance. Now, you may have heard last year that there was some concern about this technology that was raised by the FDA with both Medtronic and Guidant. And because when I discuss this subject, I think it's important to understand that the net bottom line is that these devices have had a major positive impact on our patients with aneurysms. The companies did get into significant problems with how they reported things and post-market surveillance and so on, but we believe that this is a very important advance for our patients, and that doctors need to really understand that there are pitfalls in the kinds of patients we treat. And if you can see this, these are two renal arteries. If we were to try and attach a device where the aorta itself is widening out, you can see that there's an inherent mechanical problem with getting a fixation of a device in there. And one of the things we've learned is that we need to be very careful about the patients we select and the devices we select. So today, endovascular therapy for aneurysms is a very, very effective therapy. Its long-term durability is still something of an issue, but it's improving, and we think the data are very good. Clearly, the operator experience with multiple devices is really becoming an issue, and we're learning much more and more that we're going to have to optimize a device to a patient. A one device or one size fits all policy is not going to work. Now, I alluded to the fact that we marry technologies, and before companies started making these devices, we actually had to make them ourselves. It's real hard to do that in the United States, as you might imagine. The environment's getting harder and harder every year. This happens to be myself and one of my interventional partners making what's called a stent graft, which is taking a stent and sewing on graft material. And this is, again, one of my other partners and one of our vascular surgeons constructing a device, in this case, to save a patient's life from a ruptured artery. We have been very successful in the past decade working with the agency here to try and get this technology available to us. So I'm happy to say that we've not had to make many of these devices ourselves. But the way that these devices can be employed, I think, will be impressive to you. By the way, it looks like a pretty small little device here. Here you can see the relative size. But let me show you the magnitude of problems. This is a young woman that I saw who was an athletic woman who had a lot of back pain. And she presented to her cardiologist during her step exercises getting increasing shortness of breath. I'm sure all the physicians can see the marked cardiomegaly and the enlargement of the main pulmonary outflow tract. The only history was that she'd had a laminectomy a year earlier. I think a light bulb, I'm sure, goes off in many of your minds, but to show you what the aorta looked like, you can see her abdominal aorta here. You can see a giant inferior vena cava here on the CT scan. And what can happen is that in this particular patient, here you can see an iliac artery, and a very large hole in the iliac artery has occurred. There's a laceration of the iliac artery with a direct arteriovenous shunt. And for those of you that are surgeons or other physicians in the audience, this is a pretty difficult, can be a difficult surgical procedure, especially when the veins are that large. And again, by going inside the artery, we can do a couple of things. One is we can stop the blood flow to control bleeding by using balloons to stop the blood flow. We can then put a device in that looks like a stent. You can see this here as a stent. But this particular device now has a fabric on it. And now we can put that in position, and you can see now that the arterial conduit is maintained. The shunt, which was right here, you can see a little bulging out, is closed. And this patient, in what amounts to be, she was only allowed a 23-hour outpatient by her HMO, was able to essentially have a major arteriovenous shunt closed. And here you can see the dramatic effect on our cardiovascular system a week later. And it's a somewhat dramatic, but really common demonstration, I think, about how simple marriages of technology can help. Another example is this gentleman who suffered blunt trauma to the neck, and he wound up with an acute left hemiparesis, which actually cleared. And 2 months later, he noted neck swelling in the right side of his neck. You can see an angiogram, a carotid angiogram, demonstrating this somewhat innocuous but very threatening-looking aneurysm. The patient was sent to us, again, to try and correct this in a non-surgical way. It's a very difficult area for access without actually tying off the internal carotid artery. Again, nothing in our country was approved to do this, even though devices were available outside the U.S. And we were able to, in this case, construct something, put it in the proper position, and essentially close this entire fistula. This patient has done quite well. Both of these patients now are over 4 years out. These aneurysms, this brief aneurysm diagram demonstrates conceptually how we approach problems. I mentioned to you that an aneurysm is a bubble or a ballooning out of a blood vessel, and there are several ways to deal with this. One is to actually put a conduit in, and that's a stent graft approach. Another is actually to fill the aneurysm with coils. This is how we treat aneurysms in the brain. Another is to actually isolate it and to recreate a surgical isolation by blocking off both in front and behind the aneurysm. And then finally is to somehow come into the aneurysm through the microcirculation. So that's a little bit of discussion about aneurysms, now, and a very important area of where we collaborate with vascular surgery to try and create less invasive technologies. The next area I want to briefly talk about is an area that's also of great interest to me because it affected my family personally, and that's stroke prevention and stroke therapy. And it's a somewhat more controversial area, but an area in a field that's moving along quite rapidly around the world and here in the United States. As you know, stroke is the third leading cause of death in the United States, and it's really the #1 cause of serious long-term disability. The impact of a stroke is much different than a myocardial infarction in terms of its impact on society, its cost impact, and certainly its impact on the patient. And we know that this is a problem with our increasingly aging population, since 70% of these occur in people aged 65 years or older. Now, as all the physicians here know, most of these are caused by atherosclerosis, and I'll show you the breakdown. And carotid endarterectomy is today, in fact, the gold standard. And it's based on a randomized trial called NASCET that many of you are familiar with or should be familiar with, in which patients underwent either endarterectomy or medical therapy. And in this particular study, the stroke rate, any stroke or death, was less than 6%. Severe strokes and deaths occurred at 2.1%, and mortality of 0.6%, unrelated to stroke. And this has become the gold standard for how we treat patients who have carotid artery stenosis. Part of the problems here in the United States is that in assessing what the real stroke rate is that there's a whole cohort of series that are in the literature where carotid endarterectomy results have been reported. And if you ferret this out, and this was from a study that was in stroke in 1996, and a meta-analysis was done basically showing that studies that are done without, whether they be interventionalists, by the way, or surgical studies, done without independent neurologic evaluation tend to underestimate the extent of neurologic effects that can occur from treatment of these carotid artery lesions. I just say that by way of groundwork as we move into this discussion. Now, as I showed you earlier, angioplasty and stenting has now been applied to the entire circulation. And there were many early on, even 15 years ago, who said, why can't angioplasty be applied to the carotid circulation? Well, the goal of treating the carotid artery, generally speaking, is stroke prevention. It's not an immediate outcome like we deal with coronary or PVD. It's preventing stroke over the long run. And there were many who investigated the use of angioplasty before stenting and more recently stenting. And what we found, of course, is that you can take a lesion with an ulcer, put a stent in, reestablish the lumen, get smoothing and endothelializing in the lumen, and that can be done with some degree of safety. The potential of carotid artery intervention or stenting is that it can be done with local anesthesia. It's basically an overnight length of stay, and in many places surgery is today too, by the way, including our own institution. It can be done with relative reduced procedure time and cost, and there's a potential for rapid return to normal activities. However, in all fairness, carotid endarterectomy done in excellent surgical hands is a great procedure today. They can be done with documented low mortality rates. And as I said at the beginning of this, what drives most interventionalists is to improve on the status quo. So we need to have measurable ways to improve on the status quo for us to really move forward with technology. And there is a cohort of patients who is high risk for surgery, who have already had previous surgery. And we know that surgery, as good as it is, isn't perfect. And so early on in our experience, we began applying this technology to patients who had already had surgery, or even 2 surgeries, to see whether stenting might be efficacious. And here you can see an example of a patient who had surgery, actually 2 surgeries, an endarterectomy, then a patch, and then a restenosis here on the after the second operation. But we found that the patient did benefit from placement of a carotid stent. And so that led to interest in using carotid stenting in non-high-risk patients an area of great controversy, as many of you may know, here in the United States. Here's an example of a carotid artery lesion. Following stent, intravascular ultrasound demonstrates smoothing. And we learned very quickly by following these patients that the Achilles heel of restenosis that has been the problem with coronary stenting and that has been a problem with superficial femoral artery stenting does not seem to be a problem with carotid stenting for reasons that we don't entirely understand. And that these lesions remain patent, the stents remain patent, and restenosis was pretty rare. And so we began applying this to other types of patients in feasibility studies and a number of clinical trials that are going on in the United States. And one of the things we learned early on was that stenting, in this case, could make a big difference compared to angioplasty alone. This is experience of Klaus Matthias, one of the leaders in this field from Dortmund, Germany. And what it shows is if you look at complications of carotid angioplasty in his single-center experience, the risk of neurologic complications and deaths was 4.3% in 254 patients. But in a subsequent group of patients who got angioplasty and stenting, permanent neuro complications and death dropped in half, as did the overall complication rate. So here was a situation where now we're getting data where the stent itself may, for whatever reason, confer increased safety. And more recently, he reported on his total single-center experience of 913 patients that begin to show stroke rates, major and minor stroke rates, and bleed rates that are strikingly low. Now, this is single-center experience. It's not randomized data, but it gives you some idea in this cohort of patients that were all seen by independent neurologists that there may be something to this as a way of treating these patients safely and preventing stroke. Now, I mentioned about restenosis, and a lot of the restenosis comes from the same cohort, and you can see that the 6-month restenosis rate, which is about 25% in coronary stents, is 1% here. The 6-month occlusion rate is very, very small, and more importantly, the average restenosis rate at an average of 6.1 years, or 6.1 years, is 8.1%, extraordinarily low in this cohort of patients. For reference, the restenosis rate of surgery is about 6 to 8%. So it's starting to approach an alternative that may be pretty comparable. Well, the problem with treating the brain now is that it's very unforgiving. And we know that angioplasty can result in particles going on, breaking off and going up to the target organ. And that's led to the use of filter devices or embolic protection devices. As you can see in this cartoon, the concept here now is that we could actually protect the target organ, whether it's the heart or the brain, by putting what amounts to be an umbrella or a filter up in the artery in advance of the lesion. And then by using angioplasty and other techniques, we can protect the target organ from any small particulates or other debris that may occur by chance that might threaten the outcome and improve safety. And so these devices, this happens to be an AngioGuard, but there are a number of others, and this is the process of carotid stenting, demonstrate how we can actually protect the circulation by using these new and innovative devices. And we know that these devices capture material. Here's some material in one of these devices, and there's a whole host of material that we've seen pathologically. So we believe that these are going to be an important improvement in safety for angioplasty all over, in the heart, the renal arteries, but most importantly, the carotid arteries. Now, in the spirit of innovation, I want to show you something totally off the wall. And it's something that has not been done in man yet, but something that is going to be done in man in this year. And I want to talk to you a little bit about stroke and stroke prevention. Now, I mentioned that strokes can come from a couple of different causes. When we talk about non-embolic causes, those can be infarcts that occur in the brain, intracranial hemorrhage due to hypertension. And 60% of all strokes, though, however, are embolic in nature. If we look at the embolic strokes, that's 60% of the pie. And it turns out there's a significant percentage of these. 15% come from atrial fibrillation, 15% come from arch plaque, 10% come from atheroma, and only 20% actually come from other, which happens to be bifurcation disease at the carotid artery bifurcation. So we've been interested in a challenge to try and develop a technique to prevent our patients or screen the brain from these offending things that could lead to stroke, not coming from the carotid artery, but other sources, from the heart, from the arch, and so on. And I want to show you very briefly here a concept that's an extension of this technology that I've shown you already, which instead of stenting into the internal carotid artery, which is actually to protect the internal carotid artery by screening it or filtering it in some way. I mentioned that this is kind of out there. There's a lot of great animal work already and basic science work. But here you can see what's happened is a very fine mesh. This is not a stent. Very fine mesh has been placed across the internal carotid artery with the idea of diverting particles that may be coming from the heart or other sources and diverting them into a safer location into the arteries of the side of the face to protect the critical vessels of the brain. And there's a strong rationalization for that. So that's an area of new technology that we expect first-in-man trials are going to be done probably this year, meaning 2003. So what do we know today about carotid stenting? Well, we know angioplasty and stenting can be done with relatively safe levels, comparable getting there to surgical series. I might mention that the American Heart Association meeting in November this year, the first results of a randomized trial comparing surgery to stenting in high-risk patients, patients that are identified as high-risk going into it, are going to be reported. And I'm on the executive committee of that trial, and I believe the data are going to be very supportive of stenting in those high-risk patients. We know patients that are high-risk today, we believe, can probably benefit. But there are things that we don't know. We don't know that stenting is equivalent to surgery in low-risk patients. And these are why these randomized trials are so important. We also know there are probably 20 or 30 stents on the market. We don't know whether they're all equivalent. And we don't know that all those forms of cerebral protection that I mentioned are equivalent. Well, moving into a totally different area that the interventional radiologist lives in, I want to talk to you a little bit about women's health, an area that's been a tremendous growth area in general in medicine, and an area that many interventionalists have great interest in. This involves the treatment of a variety of types of disease processes that include pelvic pain syndromes. It involves doing image-guided biopsies, treating some types of venous disease in women, including functional and cosmetic disease, and most importantly, uterine fibroid embolization. In considering this, for those of you that may know, uterine fibroids are benign masses that occur quite frequently in the uterus of women generally out of their 30s. They can occur younger. They can be associated with pain, bleeding, infertility, particularly in younger women, and disfigurement. It's estimated that 25 million women are affected, and that most of the time women are totally unaware of these, and these don't really create any problem. But of those 25 million patients, 5.5 million women a year seek treatment for one problem or another related to this. The current treatments include doing nothing or using some sort of hormonal therapy, which obviously is an issue today. There are 200 to 400,000 hysterectomies a year done for uterine fibroids, or more recently, less invasive surgical approaches using myomectomy. And one of the alternatives, of course, is to go into the arteries using small catheters and actually cut the circulation off to the fibroid by stopping flow in the feeding blood vessels. This loss of circulation causes reduction in the fibroid size and the symptoms. The uterus recovers itself because it has an abundant collateral flow. And there have been over 10,000 patients treated in 1999, and there are many, many more today. And one of the largest registries in the country is actually run here by your colleagues in Georgetown. And so it represents essentially an alternative to hysterectomy. And here you can see some of the advantages and the comparisons of the choices here. And this is an area that's of great interest to women and to many interventional radiologists who are treating these women. And here you can see an example of what it looks like. This is a pelvic circulation, and you can see all these large white vessels here, black on this one, represent abnormal blood vessels that are going to this uterine fibroid that when embolized, here you can see that you don't see any of those abnormal blood vessels anymore. The fibroids themselves can shrink and shrivel up to the point where the uterine size can be down to normal. The uterus, the symptoms of either bleeding or mass, difficulty in urination and so on can be greatly improved. So that's another area. One of the other areas that interventional radiologists have a great impact on is in cancer. And I want to spend a few minutes talking about that because there's an entire field actually it's being called interventional oncology, where many interventionalists live, and it involves supporting our patient care of cancer patients. It can involve things as simple as the image-guided needle biopsies, but also we very frequently, using image guidance, can accurately and very effectively place catheters and ports in a variety of ways. Using techniques such as embolization that I showed you, we can actually kill tumor cells, like I showed you with uterine fibroids, but kill tumor cells with liver cancer, and combining it with embolization, which is loss of the circulation, and that's embolization, a procedure where we go in from the inside, for any lay folks that are here, and cut off the circulation. And then we can combine that with actually chemotherapeutic agents, and chemoembolization is very important for treatment of hepatomas and other types of devices, and other types of tumors, metastatic tumors as well, to the liver, kidneys, and elsewhere. The other thing we can do nowadays is use that image guidance and actually use radiofrequency approaches to actually ablate with thermal energy or toxic injections tumors by using imaging guidance. And then, of course, management of the complications of tumors, including placement of filters and thrombolysis in some patients, or clot lysis. Now, one of the things that we do is we put catheters into strange places from remote locations. So we're good at getting kind of on the I-95 of the body's circulatory tree and getting where we need to go. And by doing that, we can use the catheter as a very powerful tool to deliver therapy. And we talked about treating blockages of blood vessels and aneurysms, but we can also use the vascular highway to deliver medical therapies of a variety of types. As I mentioned, treating hepatic metastases of colon cancer. There's going to be a variety of types of directed gene therapy, where these catheters can actually direct gene therapy to targeted organs, treating hepatitis C, treating familial hypercholesterolemia in the liver, up-down regulation of angiogenesis in cancer patients, where we want to down-regulate it, and up-regulating it in patients who don't have enough blood vessels. We can also use these gene therapies to actually modify tumors, to develop angiogenesis, to create tumor ablation, and also a technique called high-energy ultrasound energy. And this is an example of an experimental device where magnetic resonance, or MRI, is being actually used to guide ultrasound energy in to actually kill a tumor in this patient in a kidney. And it's a combination of a variety of types of techniques, but we use imaging to focus energy deep inside the liver, as you would with radiation therapy, but it's using ultrasound. And the advantage of this, of course, is that it's totally non-invasive. And this is something that we hope may be effective for certain types of cancer treatment. So, as I mentioned earlier, innovation is a critical thing to us. And as Dr. Dodder told us many years ago, if my fellow angiographers prove unwilling or unable to accept or secure for their patients the clinical responsibilities attendant on transluminal angioplasty, that they'll become high-priced plumbers facing forfeiture of their territorial rights if it's based solely on imaging and equipment skills. And as a result, within our own field, we've been looking at a significant transition. And you may be seeing this among your own interventionalists, and that is creating the transition from a group of technocrats where we use technology and gadgets and wizardry to get things done, to bringing in that clinical care piece that Dr. Long mentioned at the early part of this presentation. Since 1976, when I practiced in New York and then here in Alexandria, to me, taking care of patients has always been the primary practice model. The technology and whiz-bang stuff is only a secondary type of thing. We've encouraged radiologists to proceed in developing practices along those models. And in our own practice, generally someone consults an interventional radiologist the way you would a surgeon or a clinical cardiologist or whomever. We have an outpatient office where we can see patients, and we have clinical interaction outside of the procedural environment. I'd like to spend a few minutes giving you some insight, since this is about interventional radiology as a discipline, and it's a discipline that's rapidly changing, to talk to you a little bit about some of these changes. The value proposition of us as a discipline, why we exist, all right, is that we perform both diagnosis and therapy. We can improve on existing outcomes and quality of life cost effectively and less invasively. We can return patients back to daily life easier than whatever the alternative is. We can provide better initiative or alternatives to surgery, as well as handle patients too sick for surgery, that is the high-risk patients. And we do this all applying high-tech innovations. We occupy a somewhat unique position in medicine, that we use innovative cutting-edge techniques We use a variety of imaging technologies. And we're not disease-specific. Most clinical disciplines are disease-specific, as I mentioned earlier, and we're not organ-specific. And we're very good at controlling risks related to radiation and imaging. But we have limitations. We live in radiology right now. And to many people I see and many people I interact with, well, they say, you sound just like a surgeon, or you are a surgeon. And many of us feel that we are surgeons using other types of tools, in fact. And we do have boundaries within radiology, which has been a problem. We don't have enough of us, obviously. Many of us lacked the clinical skills necessary to really build the clinical infrastructure. And as a result, we've had a somewhat peculiar mindset. Well, I wanted to tell you that what we're doing internally within radiology is actually making a transformation, and I wanted to inform you of that because I'm quite happy about it, actually, and I think you're going to see over time a change in our discipline. And what organized radiology has done through the American Board of Radiology and through the American College of Radiology, which is sort of the political arm, is two critical things. One is we've redesigned a clinical pathway where someone can actually take an interventional radiology residency. They know in medical school they want to become an interventional radiologist. And what it's going to do is add back the clinical training that's been removed as part of a radiology residency. And through 12 months of a vascular interventional radiology fellowship, 9 months during residency, and 7 months of clinical training and research, you can see that we're going to be at over 2 years of really clinical training. The American College of Radiology has designated interventional radiology as an equal component. And for those of you that may know, within radiology, there's sort of diagnostic radiology, there's radiation oncology, there's nuclear medicine. And organized radiology has actually designated interventional radiology as a separate component along the lines of those, which should help us grow this into a discipline. And as I quoted Dotter before, he said that the catheter could be more than a tool for a passive means of diagnostic observation. Used with imagination, it can become an important surgical instrument. And I think that we can see over time how important this concept of using imaging and using catheters has really, in fact, created a surgical instrument. And even though we associate surgery with knives and with stitches and so on like that, it's had a tremendous impact on our whole discipline. So in the couple of minutes concluding, I wanted to leave you with a few thoughts. Interventional radiology is a very dynamic, very broad specialty, which has very silently and undramatically had a tremendous impact across the breadth of medicine in the past 30 years. By using imaging guidance and developing this concept of less invasive therapy, we can accomplish diagnosis and treatment in much less invasive ways, and that has filtered into virtually every aspect of medicine. Some of the functions, such as opening channels, closing channels, implanting devices, and delivering therapeutic agents, are things you might be familiar with. And the scope of disease is very diverse, as I've mentioned. The future for interventional radiology is one of continued innovation. In the end, that's what drives us, not doing procedures. The catheter, in fact, has become an important surgical tool, and we've talked about it to open these vessels, to deliver medical therapy, drugs, and so on. We believe that interventional radiologists will continue to become innovative and to develop these procedures as a continuing pipeline in the future as they become disseminated into the mainstream of medical practice. So with those comments, I'd like to say it's been a great pleasure to come here. It's a great honor to be the 15th in a great line of distinguished lecturers that you've had for this annual program. It is a real honor to come back and a privilege to see many of my former friends. I really appreciate the fact that you've allowed radiology to have something of an ear, particularly interventional radiology, as part of this lecture series. And I hope I've been able to give you a feel for the breadth and scope of this exciting discipline. Thank you very much. I'll be happy to answer any questions or any comments that anyone may have.
Can you just comment on the diabetics?
Yeah. The question is about restenosis rates in diabetics. In general, patients with diabetes have problems with various treatments in vascular disease, and they're higher. Restenosis rates are higher in patients with diabetes. Whether they're high enough not to have this done or to have surgery instead in the peripheral circulation, I don't think is the case. In general, patients don't do well with surgery either with diabetes in non-cardiac circulation. So that cohort of patients still gets endovascular therapy first, but the results may not be as good as a non-diabetic patient. One thing we have come to recognize is that patients with diabetes, outside of the long-term results, can have a higher complication rate. And I think recognizing that has caused us to approach our diabetic patients with much greater care, and I think actually improve our outcomes in those patients.
The concept of diverting emboli from the heart and aortic arch to less significant areas is very interesting, and I was just wondering, have you given any thought as to who you might apply this to? Should it be workable?
Yeah, the first group of patients who are going to receive those devices are patients who have had an embolic event already and have failed anticoagulation therapy. And there's Coumadin therapy has a failure rate that's fairly significant, actually, in patients with embolic disease. And if a patient has failed Coumadin therapy, that's going to be the first cohort of patients, generally with either valvular disease or atrial fibrillation, who have failed and have already had a stroke. So the first patients, in terms of first in man, we're going to get this, are patients who have already had a neurological event. And those are the patients that are really the most desperate and I think would be the most willing to participate in a clinical trial and could, benefit the most. I don't think, and it's also a cohort because of risk factors. We know that those patients, I think for those of you that don't know, if you have a transient ischemic attack and a carotid artery lesion, your risk of having a stroke in the next 12 months is about 26%. If you have an embolic stroke unrelated to carotid artery disease and you failed on anticoagulation, your risk of having another stroke is about the same in 12 months. So it's a pretty high-risk cohort in terms of stroke prevention if you had to randomize.
Yeah, one brief question here. On your comment or your slide showing the MRI-directed ultrasound, that's not been done in humans? I wasn't clear. Was that, you showed a renal cell cancer?
Right, that was an animal, right.
How would that, practically speaking, if that's done in, do you leave the tumor there, having been, ultrasound?
There are several ways of ablating tumors sort of remotely. That happened to be one that involves no direct needles at all, where it's sort of focused ultrasound, like focused radiation. And to use MR guidance, which involves obviously no ionizing radiation, you need to develop methodologies that you can do that in an MR environment. So that's experimental right now. In terms of what you're leaving behind, efficacy has not been proving. That's really more of a futuristic concept. I don't believe anything's been done in man. Now, in terms of RF ablation, where you actually put something into the tumor, a needle into the tumor and RF ablate it, that's the same thing. You leave the mass behind. And there is data supporting that, particularly for liver isolated renal masses. And we've been treating more renal patients with RF ablation who either aren't candidates for surgery or partial renal resection.
Barry, what are your current enrollment criteria for aortic endografts? Or, for example, are you placing them in patients who are at low surgical risk, or are you mostly doing them in higher risk patients?
No, well, we do a lot of high-risk patients for sure, and those patients clearly benefit. We do them in low-risk patients generally over the age of 65 or 70, depending on their general health. I mean, if somebody's in the 55 to 65 age group, my personal preference would be to recommend surgery if they're perfectly healthy. When you get to be 65 to 70, the question then becomes, are they healthy and do they have favorable anatomy? The durability of at least one of the devices is sufficient that I personally feel comfortable with using it long term if the anatomy is favorable. I think where people have gotten into problems with endografts is trying to use them in everybody and trying to make the anatomy fit to the device, which is a pretty naive thing. The device is the anatomy is very complicated. I think the great thing now is that we, like the Europeans, are going to have more than one device or two devices available. And I think we'll be able to optimize anatomy for the device, and it may help results. So generally speaking, we are on the more of the optimistic or positive side of the use of endografts. The chairman of the board of our hospital had a TIA a couple of days ago, actually. And we've just gone through this whole business with carotid stenting with him and the vascular surgeons and the neurologists and whatever. So I'm going to have to do his carotid stent next week. So I said it would be much easier if I could refer you to surgery. I think that in good hands, I think carotid stenting is going to definitely have an impact. And one thing I didn't mention is that, we're sort of focusing on technology. The whole future of medicine and the people who live in this arena, the vascular surgeons, the interventional radiologists, is a hot topic of interest for all of us in terms of what the shape of our disciplines are going to be. Any other questions? I didn't offend anybody? That's good, I guess.
Doctor, thank you on behalf of the Dolan family and my mother, and in memory of my father, we wanted to give you this plaque, and thank you very much for giving us.
Thank you very much.
I apologize to Kathleen and Tom, the grandchildren of Bill Dolan, both very accomplished folks who are here with us this evening. Welcome again and good luck, Tom. You're all welcome to come and join in the well-prepared food. It's not typical hospital, hospital food in this hospital is exceptional. You can order anything you want at any hour of the day and night. So, thank you all for coming, and please come back next year.
Thank you very much. I had a chance to meet your dad. Yeah, when I was living here. Okay. All right. Thank you very much. Thank you. Thank you very much. Yes. Yeah. Sure. Yeah.